What's the strangest thing that you found retrieving from somebody?
Some things that I've found are like flashlight handles, bowling pin tops, palm bottles, like pomegranate juice bottles, screwdriver handles, toothbrushes, whatever is available. I mean, I feel like it's been retrieved before. Hi, I'm Dr. Italo Brown, emergency physician in the Bay Area, California. Today we're gonna look at some television shows that explore life in the emergency department. First, we're gonna take a look at Pulse. In this scene, you'll see an obstetric emergency.
What's your name?
Mariana.
Uh-huh.
I thought I just had to poop. Oh, this can't be happening.
Sorry, but it actually is.
First, she's nasty because she didn't even wash her hands. This is a fact. I think that for two reasons. One, every time when we're in the emergency department, we're using sterile gloves off the bat. And I know that she's not in the ideal place to get sterile gloves, but most of the time, the first thing you do is yell help, and someone will come rushing, and you can tell them what you need. But her going straight raw hand into this actually makes the situation worse for the child, increases the risk of infection. She could get chorioamnionitis. In fact, most of the time you're giving antibiotics preemptively before delivery. This just, to me, is all bad. The term they use is a precipitous delivery. This is a delivery that is happening in a fashion that's like unexpected. So whenever you see scenes of someone like driving straight up to the emergency department and a pregnant woman coming out of the car and she's in labor actively, that's a precipitous delivery. As opposed to ones that are planned or C-sections that are planned or inductions that are planned, this is like worst case scenario.
We are gonna have to do this here, okay?
Can't you just get my doctor?
We're in the middle of a hurricane. Labor and delivery slammed, so right now I am your doctor.
Can you do this on your own?
I think that the patient is raising some valid concerns right here, okay? Most of the time, pregnant women are working with like the same obstetrician, same team, a midwife, sometimes doulas, and that relationship is what gives them comfort and trust in the process. And so I understand that she's like completely taken off guard by the fact that this is a stranger about to deliver her baby.
Oh, there's something wrong, isn't it?
All right, your baby's shoulder is stuck behind your pubic bone, okay? You're gonna hate this, but I'm gonna have to just push really hard just for a second.
Are you sure?
Look at me, hey, look at me. I know that you're scared. I'm not. So trust me.
One of the complications of delivery is shoulder dystocia. That's when a child's or the infant's shoulder is stuck on the pubic bone or the pelvis. And there are certain maneuvers that you can do to try to relieve that pressure. One is McRoberts maneuver. This is like hyperflexion of the legs, pulling them back or pushing them back as far as they can go to try to change that entry angle. And what you see her do is try to shift the child a little bit by putting pressure on top of the pelvis area. All of this to me is appropriate, and it helps her relieve that jam for a second, and the baby can come out a little bit more fluidly. Also, you know, once the baby's delivered, you need to immediately warm the baby. This baby's just like sitting there, and I'm like, hey, this ain't working. You gotta, stimulate the child, get those APGAR scores, and then warm the baby right off the bat. And so that to me is not super, like on a cold floor, fam, that's not it. I'm sorry, that's just not, it's not it. Next, we're gonna watch a scene from the Pit.
Reporter's in bad shape. What's his name? Rich Stefano. Hey, Rich, how you doing?
What you see here is a gentleman who was shot essentially through the neck and then out of the side of the lower face. These are important zones of the neck, right? And when we talk about trauma assessments, zone 2 is where a lot of structures exist. All of the arteries, the vasculature rather, and some vital organs as well as the airway is all in zone 2. Now that pathway of the bullet looks like it exits out of zone 3, which is the upper portion of the neck and the lower portion of the face. So mostly like dentition, the mandibles, possibly the tongue. What I really am worried about here is how soon until all of that trauma causes swelling inside of the mouth and then the airway becomes a concern. And then there's the possibility of actual blood being in the airway and obstructing the view, making it difficult for him to breathe, making it difficult for someone else to take control of that airway as well. The first thing you want to do is put a C-collar on this guy. You want as much stabilization as you can, given that you don't know what the anatomy actually is, right? That bullet could have ricocheted, could have hit something else, and then you could end up having a spine, like a cervical spine injury. Just because you see the exit here doesn't mean that it didn't hit more posteriorly. And then immediately start to prep my airway stuff because you know that this is gonna be a traumatic situation and possibly a surgical airway.
Move that killer to the right a little bit.
Any better?
Not really.
Anytime there is a law enforcement officer injured in any capacity, there's usually more officers that by protocol have to come to the hospital in general. And so this is very accurate in terms of the presence that you see. And even in some mass casualty events, what you'll see is more personnel present floating through the ED. So again, the visual of this is on target, highly accurate.
You doing a Craig? Yep. No skin hooks, no bougie, old school. Got a tactical airway in my bag here.
What is that?
It's a control crite kit. Oh, that's perfect. Use it on the battlefield. Works in the pitch dark when you're under fire. I can do these with my eyes closed.
I think that most ER physicians have a little set of things that they prefer to use. Sometimes they have their own kits, which might have different materials than are actually available in the hospital that they work at. Because keep in mind, like, not everybody is at an institution that is a research center or that has access to a bunch of funds, so you might end up having to come with your own stuff. Things that might be in these kits might be your own shears. As this guy has, he's got a tactical airway kit. So that control crike is like a product that's designed to make surgical airways a little bit faster, and it helps you in terms of the anatomy. If you have something to help you find the airway, this small aperture, and you can place that rod inside of that small aperture, it gives you a better chance of getting the tube in the right location in as little time as possible. In real life, this dude would be bleeding like crazy. It would be blood all over. It's not just like this clean procedure. Often doing this, you'll see like significant amounts of blood. You're puncturing through somebody and in a space that there's other structures that are deep to the incision site. But what's really cool about how he's doing it is this is like an all-in-one tool. And so the moment the incisions are made, he can basically drop in this introducer, and then it automatically has everything attached to it so you can start to ventilate right away. Next, we're gonna take a look at this scene from Grey's Anatomy where they discover a foreign object in one of the most unlikely places.
We're going to make an opening in the sigmoid colon.
Something feels hard.
There's a small bleeder here.
Stop, wait, okay.
I got
Let me
it.
get a clamp. Roy, back away!
I don't know the fascination, but a lot of people will try different objects for a variety of different reasons. But when those objects can't be retrieved manually, they end up in the operating room. And this, unfortunately, is like one of those situations where if you don't have great line of sight to what the object is, it can definitely become a catastrophe. So I feel bad for the fact that there's like lit on fire and shot around like a shooting star, but at the same time, you gotta follow instructions, man. You can't go rogue. He told you to chill and you didn't.
Let's get some laughter. What the hell happened?
Aerosol hairspray, not shampoo, and it exploded. Is he all right?
Yeah, I'm okay. More laughs. Hurry.
A part of it is driven by the stigma where, you know, folks who are exploring feel a little ashamed. And so they do this in the privacy of their homes. They do this in certain circumstances where it may not be fully safe, or they use objects without proper understanding of what it looks like to retrieve those objects.
Gotta get this bleeding under control. Get me 2 units of blood. I need 2 vascular clamps. Talk to me, Roy.
He exploded.
Not until after I told you to back away, and you didn't. Get him out of here.
Coming into the emergency department, that by itself is like a last-ditch effort for many individuals. They've tried everything at home, so you can imagine them coming in like, hey, this is an actual emergency. And sometimes they won't even tell you off the bat. You have to discover this from an X-ray or from some type of imaging studies.
Desire for a prostate massage is absolutely normal. And if you have a simple conversation with your wife and explain to her your
Please
desire...
stop. Not until you tell me what you put in there. My wife's hair stuff.
Super common. Most people have a story of what they've retrieved. Some things that I've found are like flashlight handles, bowling pin tops, palm bottles, like pomegranate juice bottles, fist dildos, screwdriver handles, toothbrushes, whatever is available. I mean, I feel like it's been retrieved before.
All right, let's bring in the power.
Okay.
Hurry.
Come on.
It's a lot going on in this scene. But did you see how no one was actually squeezing the ambu bag? Nobody. Like, that's movie magic. So This person has lost pulses and they're effectively trying to regain these pulses by doing compressions. But then they notice what I'm assuming they think is an arrhythmia. And the way to get this handled is by shocking or introducing electricity. They introduce electricity, but in between the shocks, no one is actually doing compressions or oxygenating the patient. And these are like vital steps in almost any resuscitation. Let's take a second to actually go through it the right way. You're gonna take your hand and then another hand and almost interlace those fingers. Place it directly in the center of the chest to where you feel comfortable. Apply direct pressure down about 2 inches, and then you wanna go at a rate of about 100 beats per minute. Some people find that singing the words to Staying Alive, Break My Soul by Beyonce, or Not Like Us by Kendrick Lamar help to maintain the rhythm. It looks like this. If you're not breaking ribs on the first push, you're really not doing CPR right. It should be a very deep push on the first one. Break straight through the ribs and then keep going. Let's take a look at the scene from Lioness. Here you're gonna see a needle decompression.
Okay, I got it.
Needle goes in second intercostal space.
In this scene, she essentially took a round to, it looks like the lower abdomen, like right side lower abdomen. It probably struck her liver and in the process probably nicked a lower portion of the lung, and that's why she's got this pneumothorax. What she's trying to do is instruct him on the proper placement to put what is actually not a full needle decompression. This is more like a pigtail almost. But essentially to create an area where air can be released and relieve the pressure that's building up inside of her chest. The location, she says, is absolutely on point. Usually it's second intercostal space, mid-clavicular line. So the middle of the clavicle, go down 2 ribs, and you wanna push in that rib space just beneath it. And she's also right in saying that that area has a lot of tissue, like a lot of cartilage, and so you have to use a little bit of force, which I think he's about to do.
The cartilage is thick. You're gonna have to press really hard and straight down.
You ready?
There's a part that was missed there, but essentially once they placed it in, you're gonna slide that plastic part all the way down and then remove the introducer. So you're seeing like a dilator and the actual tube at the same time, which is why it looked like it was a little longer. Once they got it in, throw the tube all the way down, and now she's got this device that's gonna help her effectively relieve the pressure that's building up in her chest or her mediastinum.
You're doing great.
This is the farthest thing from great, buddy.
That little whiz, that gush of air that you hear is kind of the one telltale sign that you now entered the right space. So we're always looking for that whoosh of air. He got it on the first shot. First of all, we gotta acknowledge that folks who are in fields where there's combat, their temporizing measures and knowledge of these things are usually higher than the general public. That's the first thing that they got right, is knowing what needed to happen right then and there. The second thing they got right is, as I said, the location. It wasn't haphazard. She actually lines up the shot, he nails it on the first time, and you get all of the signs of the fact that the lung is starting to reinflate in this one shot, and her relief is a sign of that, right? The third thing I think that they got right, which I really love, is absolutely talking through why she needed it right now. You see her talk about her blood pressure changing, her heart rate is a little lower than normal, and so this is going towards the critical zone, she is decompensating, and the accurate thing to do whenever this happens is this particular procedure. So I just think that the medicine is right, the indication is right, the actual procedure itself is correct, and the circumstance is probably highly, highly accurate. All the ER shows, y'all need to take note. Now we're gonna take a look at a scene from the classic ER.
How long have you been out?
Coming up on 2 minutes.
What about a needle crike?
Not yet.
What are you doing? I'm going in.
I said not yet.
Yeah, this is kind of bad form. When you think about patient management, often there's ownership over the patient, and so whoever is either at the head or the foot of the bed is typically running that resuscitation. For him to just like walk from one into another and then start doing something is like, it's bad form, it's like a subtle violation. I understand what his goal was because he could see that he was struggling to get the airway. Like George Clooney's character wasn't effectively intubating the patient, and so he was gonna do something in a different location. But it really isn't his judgment call at that time to do it. And I think that that's kind of indicative of microaggressions in hospitals all the time. Intubation itself is still a procedure with considerable risks, right? You never know what a person's like anatomy of their mouth looks like. Some people have big tongues, some people have short necks. Like all of these different features make getting that airway on the first pass difficult. And with every successive pass, it becomes less and less likely that you're going to be able to effectively oxygenate somebody or give them oxygen. It's not an easy procedure to do. And honestly, a lot of the television shows make it seem like it's a one-shot entity, and a lot of times it takes multiple passes.
O2 sats up to 95.
All right, start him on 750 milligrams ceftriaxone, IV, Q12. Son of a bitch.
Ultimately, the patient comes first. And so you can handle this beef outside of the ER, but at this moment, I think the decision to use the surgical airway to do a needle crike is the right decision. I think as a society, we're indoctrinated to this belief that he or she who wears the white coat is the doctor and makes the rules. And that is starting to shift significantly, right? Like in most of the emergency departments that I've worked in, people don't wear white coats. One, because it can cause a reaction for the patients. Like sometimes white coat syndrome happens where their vital signs are irregular simply because of the experience of being in front of a doctor and that trauma. And then in some situations, it actually is unsanitary. You can carry germs with this white coat from one patient to another patient. And imagine if one is like critically ill, now you've introduced something into another space simply because of the garment that you're wearing. I honestly don't think that this is the current school of thought. In fact, most people who wear white coats are doing this because it's to establish the role of a provider from other individuals in the department. Here's another scene from Post that looks at a hand amputation.
I do want to know your name though, okay? And here's why. Look at me, look at me. I need to know your name because I'm responsible for you, okay? I'm gonna bother people about you. I'm gonna worry about you.
Just so you're aware, what he's doing is distracting him because obviously the kid is like borderline panicking out, thinking about the loss of a limb while still doing the rest of the primary and secondary surveys. These are like the bread and butter components of a trauma evaluation to find out if there are any other injuries. The obvious injury is this one. You're trying to find the one that's not so obvious.
My hand. Hey. My hand, man. They're looking for it, all right? And I'm not gonna let them stop, I promise. Okay.
I think the thing we have to kind of center here is that amputations like this, when they occur, it's twofold. One is you're actually trying to save the patient's life. Thinking of, how do I stop this bleed? Is it hemorrhaging? Is it properly tourniqueted so that you can stop the blood supply and the person doesn't go into hemorrhagic shock? Then there's the extremity, right? So he lost his left hand, it looks like. And you want to be able to find that and assess the condition of the hand. If the hand is mangled, the chances of it being reattached is low. But if it's still preserved and intact, good condition, and under a certain amount of time, like 18 hours, you could put that hand inside of like some gauze that are damp into a bag that is sealed, and then put that into another container with some ice. The main thing is don't let the extremity touch the ice. It could cause deconditioning of the hand itself. It can lead to the actual cells themselves can be destroyed because of the ice that's there, the temperature change. That extremity can get what's like a form of frostbite essentially because you're transporting it and can't really temperature regulate. And so I think that when they say this, the goal is really to keep the limb preserved for as long as you can, but try to shorten that time between identifying the extremity and then reattaching. Now we're gonna take a look at a scene from 911 where the driver is impaled by a piece of steel.
Airwaves sound good.
What's your pain level?
Not much pain. I don't think there's any spinal damage. I can feel my legs, but when I try and move my head...
No! Just be still.
What's going on? Why don't you guys like cutting me out of here?
It's complicated.
Major shout out to our first responders, right? Like, First responders go to scenes like this, and they usually see the most graphic images before the physicians or any care provider sees it. Something that they got right here is that moment where he tried to move and they told him not to move. Most people think about it because, oh, it's like this thing that's impaled in his forehead, but really there are other injuries that could have happened from this accident, and you want to make him as stable as possible. Then there's the fact that this projectile that's now embedded in his head, it could shift even millimeters, and that could lead to an entire different outcome. He's relatively stable as you're talking to him, but you don't know how quickly that's gonna change. So making sure that he didn't move is absolutely the right thing to do. Reality of this is people do survive different weird kind of mechanism injuries all the time. There's neurosurgical miracles that happen, but I'd be worried about him even making it from here to the hospital. My first thing would be, how quickly can we extract him as safely as possible? That's gonna require stabilization of both the rebar, his head, his neck, and then effectively trying to transport him with very little movement from the site to the hospital. I'm surprised they didn't airlift him. Like, that would have been the first thing I would do. They literally just put the car on a tow truck and then towed the car. Now, I get it, but at the same time, it's like, to me, that seems like the worst possible way to take the person to the hospital. Now here's a scene from Scrubs.
15% of all surgical complications are anesthesia related, so I would like to use hypnosis instead of the traditional anesthesia.
With all due respect, I don't think hypnosis is an adequate way to sedate somebody for a full procedure. There's other elements that you can't control, and no matter how deep you can get someone into their subconscious, pain is pain. I'm sure someone has tried hypnosis for a variety of different things that are probably not as invasive. I could imagine hypnosis for like maybe a dislocated shoulder, or doing some other minor surgical things such as like suturing or even passing in certain types of tubes. But I don't think that this will work for like an appendectomy. Come on.
What are you saying to her?
You can do this. You can do this.
Small world. Scalpel.
Every procedure doesn't require deep sedation. There's different types. You can do moderate sedation, where a person is in, for example, like a state of euphoria or slightly disoriented to do a quick procedure. We use this like ketamine for a lot of these different things. Sometimes you can do local anesthesia, like give a nerve block and block that area and provide adequate analgesia so that the person doesn't feel the pain in that particular region because you did something smart. Women, when they give, when they're giving birth, often don't need to be knocked out, right? They get epidurals, which gives them adequate anesthesia for that particular part. So yeah, there's a variety of different things that can be done if a person doesn't want to be completely induced or sedated. But something like an appendectomy, I just can't see. I can't see without like good control of their airway and making sure that they are pain-free, because again, things go south very quickly.
I never can do this. Obi, Nobi.
Well, it's clear that over time, as these types of medical dramas have become more popular, they've gotten better at the medicine. The procedures have gotten more accurate, the circumstances and dynamics are more realistic, and that's really rewarding as an ER physician to see. I mean, I feel seen by watching some of the newer shows. And also, we've got a generation of people who are consistently getting interest in this particular field because of shows like this. So I just take my hat off and salute them for continuously approaching this with a high degree of reality, and also making sure that they honor the providers who do this for real.